staying well during this unprecedented COVID-19 pandemic. We've certainly learned many lessons, and I look forward to when these restrictions will ease. Well, we've witnessed over the last 2 decades many changes in the management of acute spinal cord injury, and I will summarize some of these with a particular focus on a concept that I call time as spine. And I think it's also helpful for all of you as clinicians and individuals who treat spinal cord injury to have a sense of where we're going to be going in the future. And so I'll be talking about some of the advances in regenerative medicine, neuroplasticity, and with neuroprotective agents. So this is a little bit about me, and this is where I work in Toronto. We have a beautiful city, beautiful skyline. And I look forward to when the restrictions ease, and would welcome any of you to come visit us. And I have a wonderful team that works with us in Toronto. We've now trained over 200 fellows from around the world, and we have a very international program. These are my disclosures. I do some consulting work with some companies that are developing technologies for spinal cord injury. I receive grant support from a number of agencies, and I will be discussing the riluzole in spinal cord injury, or riscus trial, on which I'm the principal investigator. So this is a remarkable wall carving from the Middle East, from the Persian Empire, 2600 BC. And this really highlights the fact that spinal cord injury has been a challenge which has perplexed physicians for millennia. And this wall carving depicts a lioness who's been wounded through the spine with arrows and has a flaccid paraplegia. We've made remarkable progress in the last few decades, but there are certainly many challenges which remain. And to highlight the challenges and the complexity of management, I present this case for your consideration. A 39-year-old man who unfortunately sustained a C4 level Asia A cervical cord injury after diving into shallow water. And he's a bilateral facet dislocation at C4-5 with a severe contusive and compressive injury. You can see already within a couple of hours after the injury, the ascension of the secondary injury processes within the spinal cord. So from this context, I'll present the following outline of what I would like to cover. So I'll talk about the management of acute spinal cord injury with a particular focus on the role of the timing of surgical intervention, so time as spine. I'll present a reevaluation of the role of corticosteroids. And this, of course, has been controversial, but in my view, there is a role, particularly in individuals with an incomplete injury and with a cervical injury. I'll present a reevaluation of the management of central cord syndrome, and I would argue that this is really a subset of a severe incomplete cervical cord injury and should be treated as such. And then I'll talk about a number of emerging neuroprotective therapies with a particular focus on the riluzole trial and on hypothermia, and I'll briefly mention some other strategies. Then I'll segue and I'll talk about some strategies which I think are of surgical relevance. And one approach is the use of epidural stimulation for chronic spinal cord injury. So a technique where one can stimulate the lumbar central pattern generator to evoke movement in the lower extremities, even when patients are completely paralyzed. And then I'll segue into regenerative medicine, talking about bioengineered concepts as well as cellular therapies with a particular focus on neural stem cells and Schwann cells. So these are the 4 learning objectives. So one is that I would like the learners to understand the concept of time as spine and to embrace this concept that spinal cord injury is a time-critical problem and one in which early surgical intervention can be helpful. I think we need to consider a reevaluation of central cord syndrome as a form of incomplete cervical cord injury, and it really should be treated as such. The learner is asked to be able to list the key neuroprotective strategies currently under investigation for spinal cord injury. And the 4th learning objective is to discuss the key concepts related to regenerative strategies for spinal cord injury. So in this montage, I present to you the image on the left from this patient that I've treated. And then in the middle panel, this is fortunately not this individual. This is from Rauschning's collection, but that does show a similar injury, a mid-cervical fracture dislocation with severe compression of the spinal cord, and highlights the primary mechanical injury, but also the ongoing compression, the instability, as well as some of the events occurring at a microstructural level within the cord. And one can see the hemorrhage and the bruising in the cord. On the right, this is from animal model work. This is in a rodent with an acute cervical cord injury, and we've micro-injected the blood vessels to highlight the vasculature. This shows that the anterior sulcal arteries are intact, but there's a hemorrhage and a disruption of the central vasculature. And surrounding this zone of hemorrhage is an area of ischemia, which is highlighted by this pallor. If we look at the nerve fibers in this peripheral zone, initially they're more or less intact, but over time there's a progressive degradation of these nerve fibers. And this is due to the influx of calcium, sodium, the release of glutamate, and excitotoxic mechanisms that results in neural degeneration. And then finally, this culminates in the pathology of a chronic spinal cord injury. This is human tissue, autopsy specimen from a person who died several years after a cord injury. And one sees that the area of necrotic damage has been resolved, and there is a central cavitation. This is surrounded by the pink tissue, which is the glial scar. And this is the scar that forms initially to wall off the secondary degeneration. But unfortunately, in the chronic phases of injury, this serves as a barrier to regeneration. And we now see that there's been a disconnection of these nerve fibers due to this secondary degeneration. And these nerve fibers are seen here in blue. So let's consider the concept of time is spine, so early intervention for acute spinal cord injury. And you're all familiar with the Staskas trial, which we published a number of years ago. This was done in acute cervical cord injured patients, a large multi-center trial. And in this trial, we demonstrated that patients who were operated on within 24 hours had an almost threefold higher rate of substantial neurologic improvement. And this was based on a 2 or more grade change in the Asia impairment scale. So based on this and other studies which subsequently followed, the AO group, in collaboration with other groups, issued practice guidelines for acute spinal cord injury. And the bottom line is that the practice guidelines indicate that the optimal management, regardless of the type of spinal cord injury, should be that patients should have surgery within 24 hours. But of course, there's considerable judgment that's still required. I wanted to go over in a little bit more detail the controversies and the recommendations that I would make around corticosteroids, in particular methylprednisolone. And you're all aware of the controversies, pro and con. And in light of this controversy, my colleagues and I in the AO, in collaboration with other groups, did an updated meta-analysis of the literature. And we did this in collaboration with a group of external methodologists to reduce bias. And this was some expert statisticians from Spectrum Research. And these are the forest plots that have emerged. And there's a wealth of data which have been published now 3 years ago in the Global Spine Journal. But if you look at the forest plots, we see very clearly in this meta-analysis that there is a favorable effect of corticosteroids. Now, the effect sizes are relatively small, and it depends on the type of patient that you're looking at in terms of whether this effect size is large enough to be significant. But in a tetraplegic individual with a serious cervical cord injury, any degree of motor recovery, particularly in the hands and upper extremities, can make a big difference in terms of their quality of life. Now, there are, of course, potential complications with corticosteroids, but one of the points that I want to make very clear is that there is no increased risk of mortality. And in fact, the trends are actually for a slight reduction in mortality, but there's certainly no increased risk at all. And so from this perspective, the drug has a good safety profile, there is a slightly increased risk of infection and thrombotic complications, for sure. And now the clinician has to weigh the pros and the cons of these. In cervical cord injured patients, steroids have a reduced risk of complications. So this is very interesting. We know that patients are heterogeneous. So this is data from our Staskus trial, and we had Joe Dottori from Spectrum Research undertake an independent analysis of the data, and Joe did a very elegant analysis. And on this forest plot, we see that there is a significantly reduced complication profile with corticosteroids in patients with cervical cord injury. So this is now very interesting because this suggests that cervical cord injured patients might have a unique benefit from this medication. So having done the meta-analysis, we now put this scientific information into a process called the GRADE process. And I'll just kind of walk you through this. So to do this, we had a multidisciplinary group of clinicians. These were surgeons, physicians, rehabilitation specialists. We had patients, patient advocates, healthcare administrators, nursing, physiotherapists, and so on involved. And we looked at the best available evidence. We then assessed the clinical acceptability. We took into consideration patient values, and we look at the benefits versus the harms, and then we considered the costs. And based on this, we have the following recommendations, and I'll walk you through these. Recommendation 1, when started within 8 hours of injury, we suggest that a 24-hour infusion of high-dose methylprednisolone be offered to adult patients with acute spinal cord injury as a treatment option. And we present this as an option. There's obviously judgment that is involved here. So if you have a very sick patient, if you have a diabetic, an elderly patient, you may consider that the risk-benefit ratio is not there. A young patient with a cervical cord injury, I would certainly strongly consider using the medication. But there's a time window in which the medication is effective. So we suggest not offering this option in patients who present in a more delayed fashion, so after 8 hours with an acute spinal cord injury. And so if patients are being transferred to you, you may wish to link with the referring physicians to start this medication prior to arrival in your center. And then finally, we suggest not offering a 48-hour infusion of corticosteroids. There's really not any significant added benefit to the 24-hour infusion, and this is where you start seeing more complications. So overall, methylprednisolone can be considered a valid option. There's no strong evidence to recommend against its use as an option. The decision should be left to the discretion of the physician. And I would certainly consider the use of this option, particularly in cervical cord injured patients and an incomplete spinal cord injury, particularly when this is combined with a surgical decompression. So let's now shift gears. And I'm going to now be talking about central cord syndrome. And I present this article that we published in the Lancet Neurology on the global burden of traumatic brain and spinal cord injury. And this is a major issue. And what I'm illustrating on the right here are that the demographics of neurotrauma are changing. And we're seeing an increased a population of older individuals. And this has an impact because we're seeing more and more central cord injury. So we recognize that the overall incidence of spinal cord injury is remaining stable, but we're seeing fewer major accidents in younger individuals, but more in older individuals and related to fall mechanisms. And we're seeing far more cervical injuries than ever in the past. So central cord syndrome is becoming a public health priority. Now, this is the classical description of central cord syndrome. And some of these classical descriptors remain valid, but others are no longer valid. And I wanted to just walk you through this. So it's true that this generally occurs in older individuals with a hyperextension mechanism, as Schneider described. Usually there's pre-existing spinal stenosis, often from degenerative osteophytes and cervical spondylosis. Now, what is not, however, valid are these four assumptions. It was assumed that there's a central hematoma and that the preferential involvement of the upper extremities is because the corticospinal tract has a somatic topic organization. This isn't the case. It was assumed that the clinical course is universally favorable. That's not the case. Most patients actually report a pretty poor quality of life after this injury. It was felt that surgery was unsafe. Well, that may have been the case when Schneider described this entity in the 50s, but this is no longer the case in the 21st century. And we also recognize that this population is not homogeneous, that there's a lot of heterogeneity and variability in this patient population. So let's talk about the pathophysiology. So this was the original concept, that there was a central hemorrhage, that you have the medial fibers which subserve hand function, which are picked off. And this is why the upper extremities are more involved. So in fact, this is not the case. What generally occurs is that there's not a central hemorrhage, there's a diffuse white matter injury. And the corticospinal tract is most important for hand function. And this is actually why patients with corticospinal tract injury have predominantly hand and upper extremity function. And in fact, tracer studies from primates have shown that there is not a somatotopic organization of the corticospinal tract, but in fact, about 90% of the axons subserve hand and upper extremity function. So that's the first assumption which has been deconstructed. So is the clinical course always favorable? So here is some work from the European colleagues. And essentially, these authors have concluded that it's really the baseline Asia grade and not the diagnosis of traumatic central cord syndrome, which determines the outcome. And now I'm going to present to you some novel data that we have put together. This is from 652 prospectively accrued patients with an incomplete cervical cord injury. In the red are patients who do not have a central cord syndrome, but have an incomplete cervical cord injury. And in the blue are patients with a central cord syndrome. And you can see that the outcomes and trajectory for upper limb function, lower limb function, total motor scores, and sensation are actually quite similar between these two groups. And in fact, if you do a multivariate analysis, the entity of central cord syndrome only accounts for 0.3% of the variance. In other words, it's almost irrelevant. In contrast, if you now categorize the patients as an Asia Impairment Scale C or an Asia Impairment Scale D, this is now entirely different. And the Asia Impairment Scale accounts for about 40% of the variance in the motor score and is actually quite critical in determining the outcome. So the clinical course is not necessarily favorable. In fact, it mimics the clinical course based on the Asia Impairment Scale. So is surgery effective? Well, again, revisiting the Staskis data, the answer is yes. And there were patients in the Staskis trial that did have a severe central cord syndrome. But here are some novel data, which is now under review. And this is now in over 1,500 patients, which is put together from 4 sources of data, from the Staskis trial, from the SciGen trial, from the NASCIS-3 trial, and from the prospective NACTIN registry. And if we look at early surgery defined as within 24 hours, we see that total motor score, a light touch, pinprick, and Asia Impairment Scale are all positively affected by early surgical intervention. This is very strong, novel evidence on the impact of early surgical intervention. So surgery is safe and it's effective. Now, finally, there's the incorrect assumption that central cord syndrome is somehow homogeneous. This isn't the case at all. It's heterogeneous. You have young patients, old patients, some have a fracture, many do not have a fracture. There can be falls, sometimes high energy mechanisms, there can be a disc herniation, and so on and so forth. And so in fact, if you now plot the data that I previously had presented with central cord syndrome, you see that there's a very wide difference in the trajectories of the outcomes. So this is very heterogeneous. And this is the editorial that we wrote a couple of years ago in Spinal Cord, arguing for the case for revisiting central cord syndrome. So in work that I will be presenting to you, which is now being considered for a publication, has been submitted, we wanted to look at to see whether we might have better clinical prediction models for neurological recovery and to evaluate the impact of time to surgical decompression in central cord syndrome. And so again, we did a merger of these 4 large data sets. We looked at Asia C and D injuries, neurologic level C1 to C8, and we defined the central cord syndrome as a difference between the upper and the lower extremity motor scores of 5 or more points. So the classic description of central cord syndrome. The primary endpoint was to undertake this work. So we found that the baseline severity of neurological injury and age were the strongest predictors of neurological recovery in central cord syndrome. We then continued this analysis. What we had found was actually also consistent with a systematic review of the literature, where age, the baseline Asia motor score, and the baseline Asia impairment scale were predictors. And so these were included in the model. And then we hypothesized that the timing of surgery and that the interaction between the Asia grade and the timing of surgery would be important. And again, these are the statistical analyses which we undertook. This is the consort diagram. We had 264 patients, which were ultimately available for analysis, a mean age of 50, 80% males, 20% females, 75% had an Asia grade D injury. And this is essentially the statistical model which we ended up with. And these are the key predictor variables. So age, the baseline Asia motor score, the baseline Asia impairment scale, and the timing to surgery. And so, and in fact, we see that there is a difference in terms of the Asia C and the Asia D patients. And this is probably because the Asia impairment scale is not the best for patients with an incomplete cervical cord injury because of the plateau effects that occur. So this is the timing of surgery. This is the Asia motor scores. And we see that the patients who have early surgery, particularly for the Asia C injuries, have a much better outcome with the largest changes in the Asia motor scores occurring. So I present these concepts here in terms of the reevaluation of central cord syndrome. And this is the second learning point that I was discussing. So the outcomes are heterogeneous. Age and baseline severity of neurologic injury are important predictors of recovery, but these are non-modifiable. You can't change the age and the baseline severity of the injury. You need to recognize these. But the timing of surgical decompression, or whether you operate at all, is modifiable, and this is associated with improved motor recovery. And so we trusted this prediction model would change clinical management, facilitate clinical decision-making, as well as patient counseling. So let's shift gears now. Let's consider the emerging therapies for acute traumatic spinal cord injury. And I'll talk about riluzole and hypothermia in a bit of detail. And then minocycline and GCSF are other agents that are being looked at in smaller neuroprotective trials. Minocycline is an anti-inflammatory drug. There's been a small early phase trial done out of Calgary in Canada, which has shown potentially some promising results. And we'll see where this goes. And GCSF is being studied in Japan, and this is a treatment which mobilizes mesenchymal stem cells. So let's talk about riluzole, and I have this film which I trust will project. Here we're studying patients with a cervical cord injury. I've got a subaxial burst fracture producing a primary damage to the spinal cord, and then the mechanisms of secondary injury expand this. So if we look at the microstructure of the nerve cells, sodium enters the sodium channels. There's a reverse operation of the sodium-calcium exchanger calcium enters and the cells swell. And then there's a pathological release of glutamate, an excitatory neurotransmitter. And all of these events in conjunction results in secondary nerve cell damage and glutamatergic excitotoxic cell injury and apoptosis. So in the riluzole trial, we're studying patients with cervical injuries. They're having early surgical decompression and fixation, which is modeled here in this film. And then we're administering riluzole. Riluzole is a sodium channel blocker. It binds the voltage-gated sodium channels. It prevents secondary influx of calcium, and it prevents the release of glutamate. So riluzole is currently standard of care in amyotrophic lateral sclerosis to prevent nerve cell degeneration. And this essentially reflects the repurposing of this drug. Here we undertook an early phase clinical trial in 72 patients. We had 36 patients with riluzole and 36 matched controls who did not receive riluzole. The riluzole patients are in blue. The control patients are in red, and we see that for Asia A, Asia B, and Asia C patients, there's a significant increase in neurologic recovery as measured by the Asia Impairment Scale grade change. And in addition, if we look at upper extremity motor scores, again, we also see a significant improvement in function. So based on this promising evidence, we've undertaken the RISCUS trial. This is a phase 3 randomized controlled trial. We've enrolled 193 patients. The trial is actually has undergone a suspension of enrollment because of COVID, and we're actually undertaking a pre-planned interim analysis now. So we may actually have some exciting results to report in the near future. So let's talk a bit about cooling and hypothermia. And this is a treatment which has been with us really for millennia, and which had a resurgence in the 1960s and 70s by Maurice Albin. There were efforts to try to take this into the clinic by Wells and Hansabout and others, but it was impractical to deliver, and it was eventually abandoned. And then there's been a resurgence in efforts to try to look at this, chiefly in the Miami project and then in Australia. And systemic hypothermia can be delivered by intravascular delivery of the cooled fluids. And there is a role in protection of the spinal cord during thoracic and abdominal aortic aneurysm repair. And it does have some role post-cardiac arrest to try to minimize ischemic brain injury. And this is a systematic review and meta-analysis of the animal model work showing significant improvement in animal models with hypothermia. But there are challenges to the therapeutic delivery of hypothermia in spinal cord injury. The systemic delivery is technically demanding. There are potential complications, including arrhythmias, coagulopathy, immunosuppression. It's difficult to control. The time to induce is long, and there can be other issues with regard to this. So in collaboration with Neuraxis, we've been developing tools which can be used by the surgeon intraoperatively to either protect the neural tissues or to also prevent damage to the soft tissues related to retraction. And this can be delivered by cooling soft tissue retractor blades. So for example, if one is doing a lateral approach to the lumbar spine, or if one is doing an anterior cervical discectomy and fusion, one can minimize injury to the tissues. One can also cool the spinal cord. So for example, if one is doing a complex deformity correction or doing surgery in spinal cord injury, you could cool the spinal cord tissues with dural pads, or as an alternative, deliver cooled solutions through fenestrated bone screws. And so this technology is now starting to emerge into the clinic and will be assessed in clinical trials in the near future. So shifting gears, now talking about the idea of epidural stimulation of the lumbar spinal cord to try to evoke movement. And this is work from Edgerton and Harkema in the United States. These are EMG records of a patient who was quadriplegic. And they stimulated the lumbar cord and they could evoke movement. And here I've shown the EMG records. And then last year, or I guess now it's 2 years ago, these authors published a small series of 4 patients with promising results using this technology. And this is the table of the 4 patients. And this is just some figures from one of these patients who was able to recover partial walking with assistive devices. And so this is very interesting technology, which is now being studied. Now, the challenge of chronic spinal cord injury remains, and the lack of central nervous system regeneration is a critical issue. An emerging area is the use of bioengineered scaffolds. And this is a work from the famous MIT engineer Robert Langer, who has set up a startup company called In Vivo Therapeutics. And he has developed these PLGA neural scaffolds, which have shown very promising results in small and large animal models. There's been a recent phase 1/2A clinical trial which showed safety. And then based on this, there's a more definitive trial, which is now underway in thoracic spinal cord injury. And so we'll again see, we'll have some data which will be emerging in the next few years with this. And then the final area I wanted to briefly discuss was the use of cell transplantation. And conceptually, cell transplantation can have a number of potential mechanisms. So one may potentially replace the lost cells, can provide trophic support in the form of growth factors. With certain types of stem cells, it can modulate the immune response. And in some cases, there can be secretion of extracellular matrix molecules to provide some scaffold support. There is a number of different forms of cell therapies which have been examined, but the 2 that I'll highlight, which I think have shown the most promise in clinical studies, have been the use of Schwann cells and neural stem cells. The use of Schwann cells, which are the peripheral glial cells, has a strong basic science body of evidence to support this. And the potential advantages are that one could use the patient's own peripheral nerve tissue, say from a sural nerve graft. And there's nice evidence that this can enhance axonal regeneration. One can see remyelination, and there's a potential neuroprotective role with this. And so based on this promising work, colleagues in the Miami project are still in the midst of phase 1 trials in acute thoracic and chronic thoracic spinal cord injury. And we again await the results of these studies with considerable interest. The final strategy I'll just talk about will be neural stem cells. And here I'll present this movie which illustrates the concept. So here we have the spinal cord, we have myelinated axons. The myelin sheath is formed by the oligodendrocyte and insulates the axons and facilitates conduction of the action potentials, which are provoked at the nodes of Ranvier through sodium channels. And the myelin is attached to the axon through adhesion molecules such as Casper, and there are potassium channels in the juxtaperonodal region which shape the action potentials. After a spinal cord injury, there's a central hemorrhagic necrosis which occurs of the spinal cord tissues. And there's a subtial rim of tissue which is somewhat intact, but this is a region where there's apoptotic cell death that occurs. In particular, there's cell death in the oligodendrocytes, and hence there's the loss of the myelin. And these axons become demyelinated, and in addition, there's a disturbed molecular arrangement which occurs. And this results in axonal conduction block. So one of the concepts that being moved forward is to use neural stem cells, microinject these into the tissue environment, allow them to pathfind in the spinal cord niche, and then to remyelinate the axons. And this is just one of the potential mechanisms through these work, because these neural stem cells can show other promising mechanisms of action. So this is some work that we recently published from our team, and I want to acknowledge the different colleagues working with me. And this is with the use of human spinally derived oligodendrogenic neural progenitor cells. And the concept here is that we would use the patient's own bone marrow cells. We would directly reprogram these to make patient-specific neural stem cells, and we would then modify these along an oligodendroglial biasing. But these neural stem cells would still have a tripotent lineage to make neurons, astrocytes, and oligodendrocytes, so the critical nerve cells and support cells. And we have very precise molecular patterning that we can use, which can very precisely characterize these cells as oligodendroglially biased, and we can make these very specific for the spinal cord niche. So these are tissue sections from an animal with a very severe injury. This is a vehicle control showing a severe injury. With the conventional neural stem cells, some benefits, but very striking benefits with the oligodendroglially biased neural stem cells. As you can see, a dramatic enhancement in the regeneration, plasticity, and repair of the white matter. And we see the concomitant improvements in behavioral function, BBB scores, as well as quantitative assessments of walking, for example, stride length and swing speed. So where are we right now with neural stem cells? So we've seen a number of early phase clinical trials, and we've seen a number of startup companies such as Geron, which have struggled financially, but this work is ongoing. The work has been shown to be safe, it's feasible. We have now seen a phase 1 trial in adult neural stem cells, which our group participated in collaboration with colleagues in Zurich and Calgary. There are other studies which have been underway, which have shown promise. And now currently our group in Toronto and colleagues in Japan are close to launching new clinical trials with a next generation of neural stem cell. So the take-home messages here from this talk in closing are the following. I've discussed the management of acute spinal cord injury, and I've presented to you what I think is compelling evidence to support the concept of time as spine, and that the management of spinal cord injury is time critical, and that early surgical decompression is very helpful. I presented evidence to suggest a reevaluation of central cord syndrome, and we should be treating this as an incomplete cervical cord injury. And again, if medically feasible, early surgical intervention should be undertaken. I presented evidence to suggest that corticosteroids are a valid option for spinal cord injury, and particularly cervical injuries. And then I presented a number of emerging neuroprotective treatments with a particular focus on riluzole and hypothermia. And I then talked about some other strategies, the concept of using epidural stimulation for chronic spinal cord injury. And then I talked about emerging neural regenerative strategies using bioengineered scaffolds and cellular therapies, in particular neural stem cells and Schwann cells. And on that note, I'd like to close and thank you very much for your attention, and again for the kind invitation to present this seminar.
Thank you very much, Dr. Fellings, for the thorough presentation. It was very informative, covering probably most of the questions that we have regarding acute spinal cord injury. We have actually a couple of questions. I have a couple of questions actually for you. So whenever you go for decompression in acute spinal cord injury, particularly in the cervical spine, there is always this elephant in the room regarding reperfusion injury, right? And or white cord syndrome. What's your experience with those, or the factors attributing to a reperfusion injury?
Yeah, so it's a good question. So it's critically important when we consider acute spinal cord injury to maintain the perfusion of the spinal cord. And so if you're going to take a patient early to surgery, particularly cervical cord injured patient, it's important to maintain the blood flow and to avoid wide swings in the blood pressure. So it's important to maintain the perfusion of the spinal cord. So if you have a patient, for example, that is somewhat hypotensive, and now you do the release, this is where you can particularly see this ischemia reperfusion injury. So this becomes quite critical. This is also a theoretical benefit of the use of methylprednisolone because there's a strong inflammatory component to this. And I realize that none of these medications are so great, but it does help to some degree. all right? And we have found this, and particularly with cervical injured patients. And riluzole in particularly is effective against the ischemia reperfusion injuries. There's quite strong evidence from the basic science work in this regard. And so even though the work with riluzole is emerging, it's a safe medication to use, and it's an option for you to consider using this as a potential treatment. So, and we have evidence which we've published. So I've mentioned, the trial in the 72 patients. So these are some of the suggestions that I would make to try to avoid that situation.
Excellent. And it's interesting what you mentioned regarding central cord syndrome, and the course is not much of a difference in terms of a favorable outcome when compared to other incomplete spinal cord injuries, when still it's a very common question in the training exam for orthopedics in North America there's this question that which of the following incomplete spinal cord injuries that has the most favorable outcome, and still that question is there despite the literature.
Yeah, and that has been the conventional thought, but it's in fact not the case, as I showed you. And the evidence for that is really clear. So it's really a subtype of an incomplete cervical cord injury. So if I was to say to you, if you get presented a case, we've got a guy with a central cord syndrome, you think, well, that's not a big deal, we'll just let it sit. If I say to you, we've got a guy with a severe incomplete cervical cord injury with cord compression, you say, oh my God, we better start thinking about surgery. So it's interesting how the nomenclature can kind of influence our approach to this.
Right, great. And then what dose of riluzole you guys used in your study?
Yeah, so we use 100 milligram loading dose. It's oral. It can be given orally or by nasogastric tube, and then it's 50 milligrams BID. The drug needs to be given within 12 hours of injury, and earlier is better than later, so as early as possible. And then it should be continued for 2 weeks after the injury, because this is the period of the major, what we call excitotoxic storm that occurs in the first couple of weeks after injury.
Right. Omar, you want to go ahead with
okay. So there is a question that if you have a case with a central cord syndrome with a stable spine, I mean, stenotic myelopathic patient, but complicated with a central cord syndrome, will you operate on this case or just you will observe?
No, I'll operate. And usually there's a diffuse spondylosis. So often a posterior approach will be used, and I will use internal fixation on these cases as well, very similar to the way I would manage a degenerative spondylosis case.
Okay, and there's another question, like if in Asia D or Asia B, we delayed the surgery for 5 days, is there any, we will lose anything or we'll gain, or I mean, what's your approach for these cases?
Yeah, so that's how we used to manage the patients. So the way I was taught was either non-operative management, or if we operated, we would cool the patients off. That was the conventional thinking. Now, the way I manage the patients is different. So we would prefer to operate within 24 hours, whenever possible. The one exception is if you have a patient who is medically sick. And so for example, some of the central cord patients are older and have medical problems. Maybe they're on anticoagulants, they have heart issues. In that circumstance, then sometimes you do need to wait to allow the patient to become stabilized. So that is the one situation. And in the guidelines, this is why we presented it as an option, not as a standard of care. It's an option because there are some circumstances that still require medical judgment.
There is a question here from Professor Khattab. In traumatic spinal cord injury, do you recommend going anterior posterior surgery, getting 360 degrees fusion? Or depends on the pathology?
It really depends on the pathology. So For cervical injuries, if there's a bilateral facet dislocation, I usually will do a 360. So usually I will go anteriorly first and then posteriorly. With severe central cords, usually it's a posterior multi-level. And then most of the thoracic injuries and thoracolumbar injuries, most are done posteriorly. Sometimes thoracolumbar junction with a burst fracture, sometimes I will go kind of from the front still as well.
When you go posterior, are you in favor of fusion versus motion preserving laminoplasty?
For spinal cord injury, my preference is fusion.
Omar?
Okay. So there is another question, is there's like a difference in healing of the spinal cord between animals and the human cord?
Yes, I think so. Look, animal models are animal models. They mimic what's occurred in humans, but it's not exactly the same. And rodents do have a better ability to heal than humans. So we recognize this. The biggest challenge with the animal models is that when you do the experiment, you use the same model. It's very precise. You have very low differences between the different types of injuries. That's not what we see in humans. We see all kinds of different injuries and mechanisms and so on. That's probably one of the biggest challenges that we see, that there's a lot of heterogeneity.
If you allow me, can I ask you, I have a personal question. If you see a patient with a central cord syndrome and you review the MRI and you say you can see that there is a swollen cord, so will you still operate on this kind of cases, although that the chance of reperfusion injury will be higher in these cases?
Yeah,
as you can see it is severely swollen on the.
Yeah,
on the
I will
you
operate.
will.
Yeah, I will operate. Yeah, I will operate.
Yeah.
And most of the, a lot of the patients in Staskus were my own patients. And so, the NACTIN registry, a lot of these are my patients. The NASCUS 3, I was the investigator. So a lot of these are my patients that were presenting. And the principles that Sameh asked me about it right at the beginning. So excellent anesthesia, precise control of the blood pressure, precise surgical technique, very careful decompression. I do use the corticosteroids to minimize the inflammatory component, which is a very important part of the ischemia reperfusion injury. And then I think Riluzole helps, and then excellent post-operative management. And I think if you do this, you will help your patients.
There is another question. What's the prognosis of recovery for acute spinal cord injury in the thoracic spine? Is there any difference?
Great question. Great question. So, okay, we have data coming out, which also now for the first time shows a benefit of early surgical intervention, even for thoracic spinal cord injured patients. The outcomes for an Asia A injury in the thoracic area is not as good as cervical. You don't see as high conversion rates. And I think all of you recognize this. And this is because the thoracic spine is so rigid that if you have an Asia A injury, there's a very severe mechanical trauma to the cord. Whereas in the cervical region, there's less trauma required. And so there might be a better opportunity for improvement. But having said this, we do see a benefit of early surgical intervention as well for the thoracic injuries. And we have seen some patients convert from Asia A in thoracic injuries, but it's not as high a rate of conversion as the cervical injuries.
Interesting. There is a where do you get the Schwann cells for transplantation from?
So it's not my work. This is work that's being done by particularly Alan Levy, who actually was one of our residents. Alan was actually my resident in Toronto. He's now chief of neurosurgery in Miami. He's a good guy. So they're doing it from a sural nerve. And then they have a very sophisticated strategy where they can take the Schwann cells, they can expand it in culture, so it's autologous. So they put a huge amount of work into kind of generating that.
There is a question from one of the attendees, I think, highlighting on the first question that you asked, Omar. What if there is an acute spinal cord injury? You do your X-rays, CT scans, MRIs. There is no significant compression on the cord. Would you still operate?
Yes.
Only if there was ligamentous instability.
Right.
So if there was ligamentous instability, then I would fix that. So you're kind of talking about the Skywara syndrome, right? And we see this more commonly in children. And the thinking in children is that there can be much greater ligamentous laxity. So in some children, there can be an injury which occurs, like a contusion of the spinal cord, even though there's not a fracture or anything. In children, there are cases where the patients don't require any surgery and they'll heal up okay. But I think you need to be very careful to make sure that they don't have a ligamentous injury. But there's not an urgency because there's not compression, but you want to be very careful with imaging to ensure that there's not ligamentous damage. I have looked after a few adults with a Skywara type of picture. In those patients, they all have required surgery because they've all had ligamentous damage.
Excellent.
Okay. There's a last question. We'll take the last question, and thank you for your time. What's the most important factor for the outcome for the spinal cord, incomplete spinal cord injury? Is it the age, time of injury? I mean, the time factor, or Boer Asia score? Which one is the most important factor for that's predicting the outcome?
Right. Okay. So the most important factor is the baseline level of neurological function. So the less severe, the better the outcome. And so this is related to the mechanism of injury and so on. So that's the key predictive factor.
Okay.
I think we have
thank you for your timing and for your answering it, for your lecture.
My
This
pleasure.
was a pleasure to have you on board. And actually, we took you from your OR. So
thank you very much. I'm off to the OR. I'm on call.
Stay safe.
Thank you
very much. You as well. Take care. Thank you. Thank you, everyone. Bye-bye. Bye-bye.
Bye-bye.
All right, everyone, just before we go, just a quick reminder of our upcoming webinars. So on June 24th, which is in a few days, next Wednesday, we have a very interesting webinar entitled My Worst Case. We have excellent speakers from all over the globe. They're going to be talking about some of the worst cases they have encountered in their practice. A very interesting webinar. I would encourage you all to attend it. Then on Friday, July 10th, we have the first ever joint webinar between AO Spine and AO Trauma. We have Professor Mohit Bhandari from Canada, and he will be talking about the new evidence-based medicine in the COVID era, and what worked before won't work in the future. Last but not least, I'd like to thank you all for attending our webinar. Thank you for your time. I hope you enjoyed it, and stay safe, and hopefully we'll see you soon in our coming events. Thank you, Omar, and thank you.
Thank you, everybody.